Hello and welcome everyone. I'm Tina Walia and I'm pleased to be your host today. This evening, we continue our health and wellness journey with our webinar on breast cancer. Our distinguished speaker, Dr. Mala Bahl, explores the latest preventative measures towards lowering your risk. The Ripple Effect Wellness Organization, or TRIVO, was founded by Dr. Sudhi Devanesan and Mr. Ravi Juneja in 2006. TRIVO's mission is to create healthy communities through education. One of our main goals is to inspire change at a personal level. Think of it as the ripple effect, a drop of information that challenges the status quo and spreads in ever-widening circles to make a positive influence and generate significant results. Webinar Outreach Wing, or WOW, is a branch of TRIVO, and we have been serving our community for well over 8 years. We host a number of webinars throughout the year by inviting leading medical experts to empower and educate our audience. Dr. Sudhi Devanesan is the president of TRIVO. Dr. Devanesan is a family medicine physician, an educator, and a public health activist. He was inducted as a member of the Order of Canada in 2001 for his role in health and prevention of heart disease among South Asians. He has also been the chief of Department of Family and Community Medicine at St. Michael's Hospital. It is my honor to introduce Dr. Sudhi Devanesan.
Thank you very much, Tina, for that introduction. And good evening, ladies and gentlemen, to yet another outstanding webinar. My gratitude to the Webinar Outreach Wing for inviting Dr. Mala Bahl to give us an outstanding talk this evening on the very important subject of the prevention of breast cancer. We're so pleased and delighted that she accepted our invitation. Now, throughout the year, these webinars have excellent speakers. One of them is Dr. Peter Lin, who time after time has come and given these webinars with enthusiasm, with humor, with joy, and with a lot of fun. So we would like to acknowledge this and thank him. And at a very special event, when TRIVO held its annual gala, we honored Dr. Peter Lin. It was such a joy and pleasure to do this. Thanks to Dr. Peter Lin. My thanks to the people who organized the gala, to the Webinar Outreach Wing, and to the new Health Lit group that has been formed for young professionals. You'll be hearing more about it. And now I want to introduce you to a new word. The word is Arabic and it's asabiya. A-S-A-B-I-Y-Y-A-H. Asabiya is a word that means group happiness, a synergy between people, joy between people, passion, work, collective spirits which join together during difficult times and good times to show solidarity and devotion to a common cause. Asabaya is not static but cyclical and can also be used in terms of overthrowing governments when there's a synergy, solidarity, and it can do good as well. So I leave you with that word, asabaya. And now I hand you back to Tina. Thank you.
Thank you so much, Dr. D. That was a very interesting word, asabiya, and we'd like to use that in our vocabulary going forward. Thank you very much. Before we introduce our distinguished speaker tonight, please answer these 3 questions to help our speaker understand you better. Breast cancer, living with hope. You have a family member with breast cancer. Are you concerned about breast cancer? And the 3rd question is, are there any health professionals in the audience caring for people with breast cancer? I'd like to repeat these 3 questions again. Do you have a family member with breast cancer? Are you concerned about breast cancer? Are there any health professionals in the audience caring for people with breast cancer? I would like to also remind the audience about the Q&A session at the end of the presentation, where you could submit your questions for the Q&A session that will be held after Dr. Bahl's presentation. I hope everyone got a chance to answer the poll. Dr. Mala Bahl, who's our speaker tonight, is a renowned oncologist at Trillium Health Partners, specializing in treating breast and gastrointestinal cancers. Her interest is in hereditary cancers and clinical trials. She's currently the breast cancer site lead at Trillium Health Partners, as well as the oncology genetics lead. In her personal time, Dr. Mala enjoys singing, cooking, and finding humor in everyday life with her 3 young children and her husband, who's also a THP physician. A very warm welcome to you, Dr. Mala.
Thank you so much. It's a pleasure to be here, everybody. And I want to say thank you to the organizers for asking me to speak on this topic that's very dear to my heart. I also want to thank all of you for logging in tonight. I know cancer can be kind of a scary topic sometimes, so I commend all of you for taking this opportunity to educate yourselves, maybe find out some information on protecting yourselves or a loved one. And we also can't forget that October is Breast Cancer Awareness Month. It's October 30th, so we just have today and tomorrow to learn this stuff. So I think with that, we're just going to dive right in. I do have some objectives. I'm not going to read these out to you, but essentially what I want to do with this talk is to educate you on what cancer is, what risk factors there are, and you could consider what you may need to address. I also want to review signs and symptoms and screening for breast cancer and what to do next if there is a problem. Next slide. I think the best place to start is to define what cancer is. Cancer is not one disease, but it's rather hundreds of diseases. And in this condition, there are cells that begin to grow uncontrollably and have the ability to spread to other parts of the body. In this cartoon that I have put up here, you see the left side. This is normal tissue. It could be the lining of your lung, the lining of the glands in your breast. But what you notice is that all of the cells look very uniform, they look regular, and they seem to be following some kind of pattern or rules. Sometimes abnormal cells develop, and your body is designed to catch these abnormal cells and kill them. Next slide. But sometimes this process doesn't work, and these cells, which are cancer cells, begin to grow. And as you can tell from the next 2 cartoons, they are not following the rules. The cells are bizarre and irregular, starting to push past the boundaries of which the other tissue was existing. And in the last bubble, you see that the cancer cells have the ability to grow into the blood supply. Next slide. So the thing that causes these cells to misbehave and to stop following the rules is damage to the DNA. Think of it this way. Every cell in your body has a job, and it's the DNA that's the instruction manual for the cells that tell them what to do. Over time, if the cells accumulate DNA damage, one of 3 things can happen. Your body has multiple mechanisms to fix this DNA damage. And if that happens successfully, the cell goes on to do its job just like it's supposed to. But if it accumulates damage, either certain types of damage or too much, the cell either dies or it will survive, but it's broken in some way and it stops following the rules. And that's when it's a cancer cell. There are lots of things that can cause DNA damage. Sometimes it's just the replication process, the making a copy of itself, a mistake happens. But your body has these mechanisms to fix the DNA. In some people, they don't have adequate mechanisms to fix this DNA. So it allows the DNA to get more damage. There are, of course, external factors. Radiation, like radiation from the sun, or atomic radiation or ionizing radiation can all cause DNA damage. There are toxins all over our environment, cigarette smoke, alcohol, pollution, all of these things contribute to DNA damage. Next, please. Unfortunately, cancer is common. About 45% of Canadians, or 1 in 2, will get cancer in their lifetime. And cancer is the leading cause of death in Canada and in Ontario. 1 in 4 people is expected to die of cancer. But don't lose heart, because the survival for cancer in general has been improving steadily since around 1990. We think a lot of this improvement is attributable to the screening programs we have, such as colorectal cancer screening and breast cancer screening. Next, please. The most common cancers in Canada in men, the number 1 cancer is prostate cancer, followed by colorectal cancer and lung. Whereas in women, the most common cancer is breast cancer, followed by lung and colorectal. Now you'll notice that the number 2 cancer in women is lung, whereas the number 3 cancer in men is lung. And this is because more young women are smoking than ever before. I know this is not a talk about lung cancer, but it's worth noting that this is one cancer in women that's actually on the rise. Next slide. But getting back to breast cancer, I hear it all the time. My patients tell me, everybody that I know is getting diagnosed with cancer, or I hear so much about breast cancer, the rates must be going up. We have to remember that we're living in a country where the population is growing and the population is aging. When we adjust for those factors, the actual case rate, the rate per population per age, is actually the same. And it's been the same since around 2012. We would love to see the rates go down, but at least they're not growing. What should be encouraging is this lower curve, the yellow curve at the bottom, which is the death rate from breast cancer. It is going down since 1990 quite steadily. I would love, again, for that to go down even further. So next, please. So what are the risk factors? Next. Next slide, thank you. I think the most obvious risk factor is gender. If you're a woman, there is a much higher risk of getting breast cancer than if you're a man. Your chance of getting breast cancer in your entire life is 1 in 8, or about 12.5%. Whereas if you're a man, breast cancer is pretty rare. Only 1 in 1,000 men will get breast cancer. When we see a man with breast cancer, we start to worry about other risk factors. Maybe there's something running in the family, or maybe there's been some abnormal exposures. Next. Unfortunately, age is a risk factor for most cancers. It gets back to that topic I said, which is accumulation of DNA damage. So the older you are, the more opportunities your DNA has had to accumulate this damage. So breast cancer, just like that, is also something that increases with age. It's pretty rare when you're a young woman. For example, if you're in your 20s, the chance of getting breast cancer is about 1 in 20,000. But by the time you're 50, the chance of getting breast cancer is 1 in 50. And between age 50 and 60, that doubles. You can see from the chart that I have here, by the time you're 60, the chance is 1 in 24. The majority of cases of breast cancer, about 75 to 80% of all cases, are diagnosed in women over the age of 50. Next. There are, of course, hormonal factors in women. We have observed in studies that there's a weak effect of your own body's, we call them endogenous hormones. So having your periods start earlier and having your periods end later in life, like starting before age 12 and ending after age 50 to 55, has a slight impact and an increase on your risk. Similarly, never having a pregnancy or never breastfeeding is a slight increase. I don't want anybody to panic, but it's just a slight impact and increase in risk. And that's because when you breastfeed, it actually causes a pause in the cyclical up and down in your hormones, as does being pregnant. You can't control those things, but what you can control is potentially taking hormones when you're in menopause. So there was a large study called the Women's Health Initiative that suggested that combination hormone replacement therapy for more than 5 years seemed to have a slight increase in the risk of developing breast cancer. But the good news here is that once women stopped the hormone replacement therapy, their risk started to drift down back to normal. So if you're somebody that's struggling with the menopausal symptoms, I think it's a discussion with your family doctor about the pros and cons. If it were me, I would take a low dose, the lowest possible dose, and I would take it for less than 5 years. Next slide. So I hear it all the time in my clinic. I don't know why I got this breast cancer. Nobody in my family has breast cancer. And that's, we do associate breast cancer with having a family history connection, but the majority of patients have no relatives with breast cancer, 85%. Only about 10% of people will identify what we call a first-degree relative, a mother, a sister, or a daughter with breast cancer. Another very small percent, 2.5 to 5% of people will be identified to carry a gene passed from generation to generation that increases the risk of breast cancer. Next. So if you have a first-degree relative with breast cancer, that will double your risk of getting breast cancer. So you want to have a heightened awareness of your body and of what screening guidelines you can follow. And I also want to point out, a lot of my patients tell me only their mother's side of the family, believing that it's only the mother's side of the family that can pass on an increased risk. And that's not true. If you're giving a family history to your doctors, please report the mother's side and the father's side. Next. So we also worry sometimes about inherited breast cancer, which is more than just having a first-degree relative. We worry about a gene that you can pass from parent to child that can dramatically increase risk. You may remember in around 2012, Angelina Jolie was on the cover of Time magazine, and she also wrote an op-ed in the Washington Post. And it was to explain why she had both of her breasts surgically removed. We called it a double mastectomy, in order to reduce her risk of breast cancer. And she's quoted here as saying, "I can tell my children that they don't need to fear that they will lose they will lose me to breast cancer." Now, at that time, she's considered one of the most beautiful women in the world. Why would she do this? Next slide. Angelina Jolie realized that she had a BRCA gene mutation. I told you earlier that cancer develops when there's damage to your DNA, and it happens all the time. It happens to all of us, but most of us have the mechanism to fix the DNA damage. If you have a BRCA mutation, you really often lack the ability to fix the DNA. So you accumulate DNA damage and therefore have a risk of getting cancer more often and at much younger ages. Next. So to illustrate how large the impact of the BRCA gene mutation is, I've told you that the risk of getting breast cancer in an average person is about 12% in their lifetime. With a mutation, it's about 80% in your lifetime. And at the time Angelina May had this surgery, she was about 40. The risk at age 50 is 50%. It's like a coin toss. So I think she made the right decision for her. We also see an increase in the risk of male breast cancer with this gene. Actually, the risk goes up to from 1 in 1,000 to about 1 in 15, so a dramatic increase. The risk of ovarian cancer goes up tenfold, as does the risk of pancreatic cancer. Next. So I've talked to you about BRCA. BRCA1 and BRCA2 genes are the genes we know about and we know the best. They were discovered actually in the 1990s and account for a lot of inherited breast cancer. But there's actually many more genes. I have this pie chart here, and maybe even in the time I put this talk together, they found a few more genes. It's happening all the time. If you live in Ontario and you qualify for genetic testing, you will have a blood test for a panel of 17 genes to determine if you carry something that's increasing your chance of getting cancer. I can't go into every criteria, but generally speaking, the criteria for genetic testing, by which is done, by the way, through a genetic counseling clinic, so you'd have to be referred for genetic counseling, is anybody with breast cancer under the age of 45, anybody with breast cancer under 50 who has really limited access to their family history, like if they were adopted or there are no women within their family, just like, very few women relatives. If you have breast cancer affecting both breasts at any age, if you're a man with breast cancer, anybody with ovarian cancer, and probably the most common one that I refer for is 3 cases of breast or prostate cancer on one side of the family, not both sides, but one wing of the family. You should talk to your family doctor and ask for a referral to a genetics clinic. Next. A lot of my patients have told me in the past that they don't want genetic testing. When I ask them why, they say that they're nervous about what the future holds for them, that they might get diagnosed with another cancer. They're worried about feeling guilty that they may be passing something on to their children. But I look at it a really different way. I think if you qualify for genetic testing, there's obviously a pattern that's worrisome. And having the testing is going to take the mystery out of why you got cancer or why we see this pattern. It's also going to identify your risk for getting future cancers and allow us to watch you more closely. It's going to allow you to have this conversation with relatives to protect them because they also may carry the gene. It's going to open doors for you to have more screening assessments and potentially have surgeries if that's something that works for you to reduce your risk of future cancers. Next. So far I've talked to you about a lot of stuff that a lot of you can't control, but I'm going to go ahead now and switch and talk about things that you can control, like your lifestyle. Next. Okay, so I know you probably hear about obesity. I looked at the list of all the webinars in the past, and I bet there was something about obesity in every single one of those talks. And here I go again. But the reality is that we are getting bigger, not just in Ontario, but in Canada and North America and overall in the world. 40% of Canadians are at a healthy weight, but 34% are overweight and 27% are obese. And I don't mean to, overwhelm you with this busy looking slide, but basically what it is the rates of obesity over the last 10 years by age group. And if you take your eyes out of focus, you can kind of see that all of the curves are curving upward, meaning that as time passes, more and more of us are being defined as obese. But I also want to draw your attention to the top of the graph. The top 2 curves are people between the ages of 50 and 60 and 60 to 69. And they have the highest risk of obesity. So when people come to my office and they say, why did I get this cancer? Or why is cancer so common? Is it something in the water? Is it something I've been exposed to? Maybe, but it also could be the increasing rates of obesity in that population. Next. So you're asking yourself, what does obesity have to do with breast cancer? Well, it has a lot to do with it. Estrogen is a hormone that is derived from fat. And if you draw the blood of people that are overweight or obese, they have higher estrogen levels than people that are at lean body weight. So that's number 1. So there's more estrogen. Number 2 is people that are obese have insulin resistance. And the insulin pathway and the estrogen pathway talk to each other. They're related. And both of these pathways can stimulate cellular proliferation or cellular growth. Okay, so that can promote development of cancers. It can promote a development like blood vessel growth that feeds cancers. So in general, not a good thing. And furthermore, if you're overweight after a breast cancer diagnosis and you don't lose the weight, it's going to increase the chance that your breast cancer comes back because all of these pathways are turning on cellular growth and may reactivate the cancer to grow. Next. But don't lose heart. Because you can always, I know it's one of the hardest things to do, but you can focus on trying to lose weight and be as close to your ideal body weight as possible. Studies have shown that if you're overweight and you lose 10 pounds, you can reduce your risk of breast cancer by 15%. And if you lose 20 to 25 pounds, you can reduce your risk by half. If anybody out there has had breast cancer and you're not as close to your ideal body weight, you're overweight. Losing weight is going to protect you. Next. And it's not just the weight. A lot of people are, by definition, stepping on the scale, not overweight, but they aren't active. And being active is also protective. When I have this conversation with my patients, many of them tell me, I don't have time to exercise. I can't join the gym. I don't have the finances to join a gym, or I'm too old to start running marathons. But I'm not talking about any of that. If you walk a total cumulative 3 to 5 hours per week, just at an average pace, not speeding like this woman in the picture looks like she's doing, just an average pace, you can reduce your risk of breast cancer. That is protective. So a 40-minute walk after dinner, grab your partner, grab your kids, take your dog out and go for a walk. Next. Alcohol is a toxin that's ubiquitous. It's all around us. And this is a slide from the World Health Organization outlining the risk and impact that alcohol has on cancer. I know none of you are going to be surprised when I tell you the number 1 cancer associated with alcohol is gastroesophageal cancer. And the number 2 cancer associated with alcohol is liver cancer. But I bet a lot of you would be surprised to know that the number 3 cancer associated with alcohol is breast cancer. Next. There is a definite relationship between alcohol intake and breast cancer risk. It's almost like a dose effect relationship. If you drink 1 drink per week, not per day, but per week, you can increase your risk of breast cancer, and you do it on a regular basis. It can increase your risk of breast cancer by about 10%. And if you regularly drink about 3 drinks per week, your risk goes up 20%. But 40% of Canadians are drinking more than 6 drinks a week. So that puts a lot of us in this category. And maybe knowing this is going to make you think twice when you're out with your friends and relaxing. Do I really need this or not? Next. So I've already talked about a lot of stuff, right? I've talked about a lot of risk factors. I've told you that being a woman increases your risk, being older increases your risk, having your periods early, start early and end later, your family history, but you cannot change any of that. But I want you to focus on what you can change. You can minimize your alcohol intake. You can do your best to try to work on your weight. You can try to be more physically active. And you can have really important discussions with your doctors about whether you should be taking hormones for your troublesome menopausal symptoms, or if there are alternatives, because we believe that 1 in 4 breast cancers could be avoided if you make some lifestyle changes. Next. So I'm going to now talk more about breast cancer itself. The breast is an organ that sits on top of the chest wall, the ribs and the muscles, and it's made up of a bunch of glands that make the milk, and the milk drops down through the tubes that we call ducts, like the air ducts in your house, and feeds out through the nipple, and it's meant to feed a newborn baby or an infant, okay? The cancers can start anywhere in that glandular apparatus, and if you look at the first kind of cartoon here, you see normal tissue. It's all very regular and even. And the first step is that the cells begin to start to behave abnormally. We call that atypia. Some atypia can actually show up on mammograms. You can even catch some things before they even become cancers. But if left unchecked or left to progress, you can develop something called in situ cancer, which is cancer that sits, thank you, right within the duct, doesn't have access to the blood supply, which is all around it. When it breaks through the duct, it's called invasive cancer. And invasive cancer is where it has access to the blood supplies, the nerves, and the lymphatics, and has the ability to spread to the rest of the body. Next. So the most common symptoms patients have when they go to the doctor if they're worried about breast cancer is a lump. And not just a breast lump, but you can also have an underarm lump, okay? Most lumps that people have, I just want to reassure you, most lumps are not breast cancer, but you should take everything, to your doctor, especially if it's something new, it's not going away, if it's growing, and of course, if it has any overlying skin changes. That could include redness, dimpling, like almost like a tethering or pinching of the skin overlying the lump. Definitely see your doctor. Next. Other things that I would be worried about would be dimpling of the skin. In medicine, we call it an orange peel appearance. I even tell my patients about this because it actually looks like an orange peel where you see like divots in the skin, and it may even be stretched and shiny in some places, but there's kind of dips in it. And that means there's something swollen right underneath the tissue. If you see crusting around the nipple, if there's a nipple discharge, especially if it's bloody, if suddenly you notice one of your nipples is inverted, I would definitely take that to your family doctor. And even if you don't feel a lump, if you notice swelling or a change in the shape, go see your family doctor. Some of my patients tell me, I didn't go to the doctor when I noticed, any of these symptoms. And I say, why? And they said, it didn't hurt. It didn't hurt. It wasn't bothering me. So I decided to sit on it and watch it. Don't do that. Most breast cancers are painless. Most patients will not have pain. That's a rare symptom. Next. I put up this slide for self-exams, mainly because I think you may see your family doctor or your nurse practitioner once or twice a year, maybe, and have an exam. That's one day out of 365 that somebody has a chance to catch something on an exam. But you have your own body with you 365 days a year. So it's really important to get to know what's normal for you. Some people are lumpy, some people have asymmetry, and it's important for you to be aware of change. And the only way to do that is to check yourself out regularly. I would suggest picking one day out of the month. Maybe it's the day that your birthday falls or your child's birthday falls or what have you, or the first of the month. And you would come out of the shower, maybe do a visual inspection, lie on the bed with your arm up, kind of stretching out as much skin as you can, and examine yourself in a way that you're using the pads of your fingers and you're not missing any tissue. In the first picture, they're doing circles, like almost like a swirl coming outward. The second picture, they're doing spokes of a wheel. The third picture, they're going up and down. It doesn't matter. Most of the things you're going to find are going to be benign. But if you find something that's different or changed, you really should see your doctor. Next, please. Okay, so examining yourself is great, but I don't want anybody to wait until they feel something. The average size of a breast cancer that's found by accident is the size of a walnut, okay, 35 millimeters. The average size of a cancer that's found by someone who's doing regular exams but not having any mammography is the size of a grape, about 2 centimeters. The average size of a breast cancer that's found on somebody's first mammogram, like if they happen to find a cancer, is the size of a pea, so a centimeter, much better. And the average size of a cancer in somebody who's having regular mammograms is 5 millimeters. Next. Mammograms have been shown to reduce the risk of cancer death, okay? And mammograms are certainly not perfect. I'm not going to tell you that they're comfortable. I'm not going to tell you I look forward to mine, but because it's an appointment and it can hurt sometimes or be a little uncomfortable, and sometimes it's cold, but they can identify cancers as small as a grain of rice. And the earlier you find a cancer, the less you need me. It may result in less treatment and a much higher chance of a cure. In fact, finding cancers in the early stage 1, results in a 98% chance of cure. Next. Okay, so what are the guidelines? These guidelines are actually pretty new. In the Ontario breast screening program, if you're aged 50 to 74, you will be enrolled to get a mammogram every 2 years. But just this past fall, they've started to include women from the age of 40 to 49. But they're not part of the Ontario breast screening program. You can self-refer for a mammogram between 40 and 49, or you can call Health 811, which is Ontario, like a provincial-based call-in center, and they will help you arrange a mammogram. So if you're 40 to 74, you're considered average risk. There's no mutation that we know of in your family. You're eligible to get a mammogram every 2 years. Now, if you're over 75, you're not part of the Ontario screening program. It's unfair because 75 is young nowadays, but when the trials were done, they didn't include women in this age group. If you are over 75 and you're healthy, you're looking after yourself, you're going to the grocery store, you're cooking your meals, you're looking after your house, I think you should talk to your family doctor about getting a mammogram. If your life expectancy is greater than 10 years. Next slide. If you happen to fall into that high-risk group, and remember, I said high-risk group was the people who have a known genetic mutation, or in this case, also people that are first-degree relatives of known genetic mutation carriers. There is a high-risk breast screening program in Ontario for anybody aged 30 to 69. That includes an annual mammogram and MRI. Next. So you've learned about your risk factors. You've learned about how to examine yourself. You've gone for your mammogram and it's abnormal. What happens next? Don't panic. We have to first make a diagnosis. And the only way to diagnose breast cancer is not with a mammogram or anything like that. It's with a biopsy. And a biopsy means removal of tissue from the breast, done one of three ways, and it's examined by a pathologist. You might have a fine needle aspiration in the doctor's office. You might have something called a core biopsy, which is done in the radiology department, sometimes with an ultrasound or MRI. Or you might have to go to the operating room and have something removed. But nonetheless, only a pathologist will be able to tell us that you have cancer. But they give us a lot of information. They're now able to tell us a lot of characteristics about the cancer, if that's unfortunately the diagnosis. And we can direct our therapies specifically for you, which could include maybe just tablets, maybe just radiation, maybe nothing except for surgery, or targeted chemotherapies. Next. Okay, so yes, we're at the tail end of Breast Cancer Awareness Month. I hope everybody is aware. I think it's really important to focus on prevention because I would love to see all of you guys, but I don't want to see any of you in my office. Practice healthy lifestyle, the same boring stuff that I'm sure people have talked about. I say boring in quotes, that keeps you free of diabetes, heart disease, and strokes will also reduce your risk of breast cancer, which means being physically active, minimizing your alcohol and smoking, losing weight, and going for your screening tests. A common question patients have for me is, what can I eat or what vitamins can I take? There's not a lot of good evidence on vitamins, but I tell all of my patients to take vitamin D, 2,000 units a day, because we live in a country without a lot of sunshine. And there's some evidence that suggests that vitamin D levels are associated with the development of cancer, and also studies that show it's associated with prognosis. Next. So in conclusion, breast cancer is unfortunately common. There's lots of things about your risk that you can't change, like your age, your family history, when your period started, but there's lots of stuff that you can do to change and to protect yourself. Most women should get a mammogram every other year starting at age 40. You might qualify for genetic testing, which may open doors for enhanced screening and other interventions, but definitely report any lumps or changes to your doctor or health professional immediately. Next. Okay, I'm happy to answer any questions.
Your expert advice on preventing breast cancer has been very useful for me, and I'm sure for our audience as well. Thank you, Dr. Mala. I'd like to inform our audience that the webinar recording will be emailed to the email used for registration for this webinar, as a lot of our audience members are inquiring about the recording. I would now like to invite Dr. Sudhi to moderate the Q&A session with Dr. Mala. Please submit all your questions through the Q&A chat box, and we will try to get to as many as possible. Over to you, Dr. D and Dr. Mala.
Mala, thank you so much for that excellent, excellent talk. Very informative, very clear, and very educational. A lot of things that are changing rapidly, and you brought that to our attention. I have a personal question I'd like to ask you. With the introduction of GLP-1 inhibitors, is there a place for things like Ozempic, any of those that are being utilized for high-risk patients for breast cancer?
So I personally don't recommend it for my patients. I don't prescribe it, I should say. But if, losing weight, especially in menopause, can be a major challenge. And I would support, if all other avenues have been, exhausted, I do think it's a reasonable choice to reduce excess body fat, because that will likely also reduce insulin levels and estrogen levels. I think it would be protective. I have not seen a specific study answering that question, but I think any efforts for weight reduction will be protective.
Thank you. First question that came in even before the webinar started was a question that a mammogram was done and classified as category C. Could you please explain what that means?
So mammograms are not perfect. And one of the reasons younger women, there was always a big debate about whether to include women between the ages of 40 and 49 for mammograms, because younger women have more dense breasts. So category C is an indicator of density. It's an indicator of moderate density. Certainly, there's also actually a category D, which is even more dense. So it's an indicator, like the mammogram is looking for shadows and white areas on like a black background. And the more dense your breasts are, the harder it is to find something. And younger women typically have more dense breasts, and it's harder to find something. So that's an indication that the radiologist is saying, this is moderately dense. We might miss something, but modern mammograms are actually quite good. This is something that should be coupled with a physical exam. High density breast tissues may need some additional testing. Like, there is a discussion going on actually amongst my group, to be honest, about whether we should be doing MRIs on patients who have dense breasts. And the reason it's a discussion is it's a capacity issue in the province. Having access to the testing, we can't make the recommendation without access, but certainly if you receive a report that says density category D, I think it's a good discussion to have about whether an MRI would be a better test to see through all this dense tissue.
Thank you. Is there any advantage of a mammogram over an ultrasound, particularly if a mammogram is painful and uncomfortable? Would it be more, as accurate, or is there a difference?
So ultrasound by itself is not sufficient. It will not detect enough. So should it be coupled with a mammogram? There may be certain instances where an ultrasound is done as a confirmatory test. Something is identified, we're not sure what it is, so an ultrasound is done. Ultrasounds are really good at detecting solid versus liquid, but your breast tissue is solid and cancers are generally solid. So it's not adequate by itself. I hear this a lot from patients saying, can't we just do an ultrasound? I'm waiting for the day that somebody comes up with a painless mammogram. That doesn't exist. But I would not, I don't know who asked the question, but I would not recommend ultrasound by itself.
Okay, thank you. The application of bioidentical hormones, estriol and progesterone creams, do they have the same risk factors post-menopause as other HRTs? She's been told that you cannot stop a bioidentical.
I don't know what cannot stop a bioidentical. Bioidentical hormones are thought to have less impact on breast cancer risk. The Women's Health study that I quoted did use older formulations of hormones. We're using more up-to-date and modern. If you have significant other risk factors, I would still be cautious. But if you have symptoms that you need to deal with, I think topical would probably be safer. And I think bioidentical would probably be less potent and less of a risk. But I wouldn't go so far as to say it's absolutely no risk, especially if you're somebody that has an extremely high risk of cancer, like a gene mutation carrier or something. Or you've already had a breast cancer. If you've already had a breast cancer that's sensitive to estrogen, you might want to avoid those. So it's kind of a complicated question, but probably less risk.
Okay. Can breast cyst lead to cancer?
Not really. Cysts are usually just very bland on the inside and don't have that thing called atypia. It's the abnormal cells. So if you have a biopsy or an aspiration, cysts sometimes have fluid in them. And there's no mention of anything called atypia, which is a precancerous situation. Cysts in and of themselves, I sort of say to patients, it's just like you have a freckle and I have a freckle. It's a freckle on the inside. I wouldn't worry about it.
Okay. So what percentage of women can get cancer a second time, breast or any other location?
So I think if you're talking about after surviving one breast cancer, curing that, what's the chance of it happening again? I usually tell patients it's about 1% per year increase, 1% per year increase. And again, this is an answer that kind of depends. Some breast cancer treatments involve hormone blocking tablets like tamoxifen, and tamoxifen is protective, and that will actually reduce that 1% per year by half. The other part of the question was, how about in other organs? That depends on if that original cancer spreads, I believe. And that's a very individualized assessment about how high risk the first breast cancer was. But generally speaking, if you've had breast cancer once, your risk of, right, whatever factors caused one side to be affected, genetics, environment, diet, whatever it is, we can't explain, it affects the other side. So yes, you should be concerned about the other side, but it's 1% per year.
Thank you for that answer. A high-risk patient, strong family history, 76 years old. Do you advise a combination of a mammogram and ultrasound or MRI every 2 years? Any of those three or a combination thereof?
So I'm assuming when they say high risk, it's based purely on a number of patients in the family, not high risk because there's a genetic mutation.
That is correct.
Yeah,
Strong family history.
yeah, and at 75, mammograms are easier to read. I would probably say once every 2 years would be fine, unless that patient has mammograms, like they have increased breast density, so making the mammograms harder to read, then you may want to couple it with another test. Or if, a lot of patients have had, I would say once every 2 years would be adequate.
Yeah. Now you mentioned environmental and radiation. Using UV for hair removal, does that and radiation coming from microwaves, are these things to be concerned about in terms of exposure?
So microwave radiation is not considered ionizing. It's the ionizing meaning that it's disrupting the cellular bonds. So that's not the case. And I don't believe they use UV light for laser hair removal. They do use UV lights in tanning beds. So tanning beds are a no-no. Okay. They use UV light when you go to the nail salon to try to make your nails grow faster. Also a no-no. There have been cases of melanoma or skin cancer that have developed in the nail beds. But laser hair removal does not use ionizing radiation.
Okay, thank you. This person was diagnosed with stage 1 breast cancer at the age of 39. A lumpectomy was done, 19 rounds of radiation, and has been on tamoxifen 20 milligrams, having several side effects. The oncologist who she sees insists that she stay on tamoxifen despite the side effects? Is there an option to tamoxifen?
There are alternatives to tamoxifen, but it will probably be worse. Because tamoxifen is the only medication for young women. Tamoxifen has a lot of benefits, and this is where that question of what's my risk of the cancer starting on the other side. Tamoxifen is a medication that's going to not just treat the cancer you've had, but it has a protective effect on cancers that you might have. Certainly, I have a lot of patients who say, I don't feel I have this side effect or that side effect on tamoxifen. I think it's important to take them apart and figure out how to make your quality of life optimized, because it is a life-saving medication. At 39, there's not just the worry about curing your previous breast cancer, but at 39, we're not talking about 5-year survival, we're talking about 50-year survival, right? So I think taking this medication for prevention of something else going wrong in the future is really important. So your doctor should address what your side effects are. A lot of people have problems with hot flashes. I tell patients to try taking it at a different time of the day. And there are some medications that can help reduce the intensity of hot flashes. If that, I don't know what the particular side effect is, but that might help.
Thank you. That was a very helpful answer. For severely obese patients, because of the high risk, should mammograms be done more frequently?
I haven't seen any evidence of specifically focusing on obese patients, unless it's a difficult exam. I wouldn't say, I mean, there are different bodies. The American College of Radiology says mammograms should be done once a year. The Canadian guideline bodies say once every 2 years is enough. And it's based on like intense analyses of the data, looking at the population as a whole. If there are specific issues with a particular patient, obviously we have to personalize these guidelines, but in general, I don't think that would be a reason in and of itself to do it more frequently.
Okay, so we're coming to the last 2 questions. One is an interesting one. Can a mammogram actually increase or aggravate the possibility of causing cancer? And the other one was, if you've already had a hysterectomy, oophorectomy with both ovaries removed, do you have to continue on the same routine mammograms?
Yes. So I'm going to answer the last question first because it's the freshest in my mind. So yes. So as I said, the risk of breast cancer goes up with age. So most women are going to have menopause by 55, but the risk of breast cancer still goes up. So their ovaries aren't making estrogen. So having your ovaries out at a young age can reduce your risk of breast cancer to a certain extent, but I wouldn't say it's sufficient to change the recommendations for mammography and screening. It may modify your risk, but I wouldn't depend on that and sort of skip out on the other things. And what was the other question?
If you've had can mammograms actually cause cancer?
Yeah. So this was another thing that's been looked at in trying to create the best guidelines for our patient population. And yes, mammograms have a small amount of radiation. But there is, we call it, radiation's measured in a unit called millisieverts. So a mammogram has 0.4 millisieverts, but the radiation in our environment that we are exposed to every day just by living is 4 millisieverts. So it's a fraction of the amount of radiation we have in our environment. And the benefits outweigh the risks. So is there evidence that having a mammogram causes breast cancer? No, but there are concerns about, excess mammography, or starting too young or doing it every year, and that's one of the reasons our recommendations are for every other year. But I've never seen it aggravate or feed a breast cancer, if that was the other question, having the mammogram causing it to kind of grow. In fact, radiation is a treatment to kill breast cancer.
Thank you so much, Dr. Mala. Excellent answers, very clear. And I think our audience is very, very happy with the way you tackled them. We appreciate it very much. And now we will hand this back to Tina.
Thank you very much, Dr. Mala, for your insights. Thank you, Dr. D, for moderating the Q&A session. And thank you, audience, for your intriguing questions. And I hope a lot of them got answered. I would now like to invite our illustrious leader, Smita Chandra, to say a few words. Over to you, Smita.
Thank you, Tina. Hello, everybody. Thank you so much for attending the webinar this evening. We really hope you enjoyed it. Thank you, Dr. Mala, for your wonderful and informative presentation. We have learned so much from you today. And thank you, Dr. D, for introducing us to another lovely new word and for moderating the Q&A session. I would love to thank our team that works very hard to bring you these popular webinars. Our wonderful MC, Tina Walia, for hosting the webinar and creating the slideshow. Sridhar Rao for tech and Zoom support. Dr. Asha for distributing our flyers, extending our outreach, and connecting with our community organizations and partners. Ashima Jain for running the slideshow tonight. Eshna Roy for creatively designing our flyers and slides to make them bold, beautiful, and eye-catching. And a huge thanks to our ambassadors, Roisin and Paul O'Hara, Jamie Sinton, and Dilpreet Bansal, who have tirelessly helped us distribute our flyers. Thank you for supporting, attending, and promoting our webinars, dear friends. We would love your feedback about how we're doing and what you would like to see in future webinars. Please answer this short and simple survey to help us out. It will just take a few minutes of your time. How useful did you find this webinar? How did you learn about this webinar? Either from an email from Trivo or Smita, Dr. Sudhi Devanation, family and friends, the local library or community center, Sheridan College Health Clinics, city halls, or any other venue that you may have seen our flyers displayed at. Do you intend to attend our upcoming webinar, The Obesity Epidemic, on January 29, 2025? What topics would you like us to present in the future? Please let me know. If you find that there is not enough time to answer this poll, please feel free to email me with your suggestions, and I assure you they will be taken very seriously, and we will try our best to accommodate your requests. If you have enjoyed our presentations and would like to support us, please donate to our outreach through our website at www.trivo.org. We are delighted to tell you about our upcoming webinar on obesity and weight loss with Dr. Lauren Grossman. Watch out for our next webinar when we send out the new flyers in the new year. Thank you so much for spending the evening with us. I'm now going to hand it back over to Tina. Thank you and good night.
Thank you, Smita. On behalf of the webinar outreach wing of the Ripple Effect Wellness Organization, I would like to thank you all for attending the webinar tonight. See you at our next webinar in January 2025. Wishing you all a good night.